Assalamu alaikum. I would like to explore the topic of metabolic acidosis and alkalosis. Okay, start with this. In metabolic acidosis, there are two types of metabolic acidosis on the basis of anion gap. On the basis of anion gap. Anion gap is sodium minus chloride plus bicarbonate. So normal anion gap is 8 to 12 milliequivalent per liter. So on the basis of anion gap, it is divided into NAGMA, that means normal anion gap metabolic acidosis, and HAGMA, high anion gap metabolic acidosis. HAGMA, high anion gap metabolic acidosis, the cause you can remember via these mnemonic called MUDPILES. This is a very famous mnemonic. There are also plenty of mnemonics like gold mark written in the first step, but I found it easier and it covers all the questions. I feel like that. Okay. M for methanol, U for uremia, D for DKA, P for propylene glycol, I for isoniazid, which is an anti-TB drug, I for iron, L for lactic acidosis, E for ethylene glycol, and S for salicylates. Okay, and the NAGMA, normal and metabolic acidosis, that is, you can remember via HARDUPS, hyperalimentation or hyperchloremia, Addison's disease, renal tubular acidosis, diarrhea, acetazolamide, spironolactone, and saline effusion, excessive saline effusion. These are the cause of normal anion gap metabolic acidosis. Okay, this thing pH will decrease 0.08. Remember this 0.08 for every 10 millimeter of mercury. For every 10 millimeter of mercury of acute increase in PaCO2. Normal PaCO2 is 40. So in here CO2 is 60. So 2025. So in patients with CO2 65 should have pH 7.2. When when compensation kicks in, pH will increase closer to normal. So in here pH is getting low. Normal pH is 7.4. So if we calculate like 0.08 into 2 and half, actually 2 and half, then we can found that it is closer to it is according to these calculation. It actually follows these calculation. So if pH is lower, like if pH is 7.2, so how we can calculate? So if pH is 7.2, that means according to law, pH will decrease 0.08 for every 10 millimeter of marker of acute increase in PCO2. So as it is 65, so 25 millimeter of mercury is raised, and if we calculate according to this rule, then we can get the closure of the pH, which is closer to normal, that they are trying to mean. Okay, workup of high anion gap HAGMA, high anion gap metabolic acidosis, drug ingestion like salicylate, early respiratory acetosis like salicylates, early respiratory acidosis. Drug ingestion like salicylates, early respiratory alkalosis, isoniazid, and iron. These are the drugs can cause high metabolic acidosis and hypoperfusion, like increased serum lactic acid, which will cause lactic acidosis, renal failure, increased BUN, and which will increase uremia, hyperglycemia, urine and serum ketones, and it will cause DKA, an osmolar gap, ethylene glycol, urinary calcium oxalate crystal, methanol, which will cause blindness, and propylene glycol, osmolar gap. Normal osmolar gap is less than 10. Normal osmolar gap is less than 10. And how we can calculate this osmolar gap? We can calculate this osmolar gap or osmolarity, calculated osmolarity, 2 into sodium plus glucose by 18, which is milligram per dl, and BUN by 2.8. So 2 into sodium plus glucose milligram per deciliter by 18, and BUN milligram per deciliter by 2.8. Normal osmolar gap is measured osmolarity, what is given measured osmolarity, and the calculated osmolarity. This is the normal osmolar gap. Okay, there is a very important question, like what is the likely cause of anion gap metabolic acidosis with a recent seizure? Um, Somebody comes with seizure and you are confused, is it true seizure or pseudo seizure? What you can do, you can do the lactate level. If there is post-ictal lactic acidosis, it is transient and typically resolves without treatment. It is transient and typically resolves without treatment. Sorry, typically resolves without treatment within 90 minutes following resolution of seizure activity. Lactic acidosis is most commonly seen in state of hypoperfusion and shock, sepsis, cardiogenic shock. Lactic acid may also be elevated in patients with end-stage liver disease. Lactic acid may uh, be elevated also in end-stage liver disease as lactic acid is metabolized in the liver. Why normal anion gap is also referred as hyperchloremic metabolic acidosis. Normal anion gap called hyperchloremic metabolic acidosis because chloride level rise to the balance out of the low bicarbonate. In here, chloride level rise to balance out of the low bicarbonate. Sodium minus chloride increase. plus low bicarb. So that's why normal anion gap is also referred as hyperchloremic metabolic acidosis. Okay, the risk and benefits of treating acute metabolic acidosis with sodium bicarbonate are not entirely clear. However, it is generally recommended in patients with severe acute metabolic acidosis with pH less than 7.1. Administration of sodium bicarbonate may cause myocardial depression and increase lactic acid production, and therefore in patients with pH more than 7.1 the relatively small benefits of sodium bicarbonate and do not typically outweigh the risks. Okay, there are something like for metabolic acidosis, there are something you need to remember. First, you need to remember Winter's formula. For metabolic acidosis, you need Winter's formula. How Winter formula is calculated? Winter formula is expected PaCO2, expected partial pressure of carbon dioxide equal to 1.5 into bicarbonate plus 8 plus minus 2. 1.5 into bicarbonate plus 8 plus minus 2. This is the Winter's formula. That means expected PaCO2 is 1.5 plus bicarbonate plus 8 plus minus 2. If there is HAGMA like high anion gap metabolic acidosis, there is a saying called delta gap is calculated. Delta gap is calculated. Okay, how we can calculate delta gap is sodium minus chloride minus 36. If it is minus 6, it is mixed HAGMA and NAGMA. If it is minus 6 to if it is minus 6 to plus 6, if it is minus 6 to plus 6, if it is minus 6 to plus 6, it is only HAGMA, that means high anion gap metabolic acidosis. If it is over plus 6, it is mixed HAGMA and metabolic alkalosis. It is mixed HAGMA and metabolic alkalosis. So this is the delta gap you need to remember. So for metabolic acidosis, if it is acute or chronic, we need that expected PaCO2. So expected PaCO2 is 1.5 into bicarbonate plus 8 plus minus 2. Okay, you should remember this. Now renal tubular acidosis. Renal tubular acidosis. What is the likely diagnosis in elderly? What is the likely diagnosis in elderly diabetic with non-anion gap metabolic acidosis? That means NAGMA, non-anion gap metabolic acidosis, hyperkalemia, and mild renal insufficiency. So NAGMA, increased potassium and renal insufficiency, increased potassium and renal insufficiency looks like type 4 renal tubular acidosis, most common in elderly patients with poorly controlled diabetes, damage to the juxtaglomerular apparatus, in hyporenemic hypoaldosteronism. Top three differential of non-anion metabolic acidosis is diarrhea, RT, and Addison's disease. So non-anion metabolic acidosis, the main three differential: diarrhea, RT, and Addison's disease. So this is RT 1, 2, and 4. 4 for potassium high, and 1 and 2 there is low potassium. Potassium is low. In 1 there is stone formation. In 1 pH is more than 5.5. So 1 pH is more than 5.5, and 2 and 4 pH is less than 5.5. In 1 there is poor hydrogen secretion into the urine, poor hydrogen secretion in the urine. In 2, poor bicarbonate reabsorption, and type 4 is aldosterone resistance. So type 1 poor hydrogen secretion, type 2 poor bicarbonate reabsorption, and type 4 aldosterone resistance. In renal tubular acidosis, genetic disorder, medication, autoimmune Sjogren's, type 2 Fanconi syndrome, multiple myeloma, carbonic anhydrase inhibitor, and type 4 is obstructive uropathy and congenital adrenal hyperplasia. Obstructive uropathy, congenital adrenal hyperplasia. Okay, type 1 alkali therapy, sodium bicarbonate, sodium citrate. Type 2 alkali therapy, potassium citrate. Type 1 sodium bicarbonate, sodium citrate. Type 2 potassium citrate, and type 4 fusamide mineralocorticoid replacement. Renal tubular acidosis in infants commonly presents with failure to thrive in the setting of NAGMA, normal anaerobic metabolic acidosis. Causes of elevated urine pH is type 1 RTA, UTI with urease positive, UTI with the urease positive bug, UTI with the urease positive bug, Proteus mirabilis, where pH is more than 5.5, and magnesium ammonium phosphate stones. So NAGMA and increased urine pH looks like type 1 RT. Now, metabolic alkalosis. In metabolic alkalosis, there are there is a very high L chart. First, I think that we should remember this chart. This is a must know chart. Metabolic alkalosis. pH is high, PCO2 is high, and bicarbonate is high too. Normal bicarbonate is 22 to 28, and like 24 is in between. 24 is the standard. If it is pH is more than 7.45, and if bicarbonate is more than 24, it is metabolic alkalosis. Then the next thing you should do, when you find a patient with metabolic alkalosis, do urine chloride. If urine chloride is low, if urine chloride is low, that means it is less than 20. Low, no response. Low IQ, no response. Saline, sorry, a low, go slow. So low, go slow. That means it is saline responsive. Slow, the causes are vomiting, nasogastric aspiration, and diuretic overuse. So low, slow, saline responsive, and high urine chloride. If it is high urine chloride, so high, not go with the flow, not go with the flow. That means saline is unresponsive. So low, go with the flow, that is saline responsive, and high, not go with the flow, that means saline unresponsive. It may be hypovolemic, it may be hypervolemic. Hypovolemic is Bartter and Gitelman syndrome. Hypervolemic is excess mineralocorticoid activity. Primary hyperaldosteronism, Cushing disease, and ectopic ACTH. Primary hyperaldosteronism, Cushing disease, and ectopic ACTH. Okay, in metabolic alkalosis, it may be acute or chronic. So, for 7 millimeter of mercury increase in PaCO2, 7 millimeter mercury increase in PaCO2 per 10 milliequivalent of bicarbonate, per 10 milliequivalent of bicarbonate. So it is 7 and 10. 7 millimeter increase in PaCO2 per 10 milliequivalent of bicarbonate. Okay, so saline responsive, these are the cause: vomiting, gastric suctioning, diuretics, laxative abuse, and decrease oral fluid intake, volume depletion, and saline resistance, primary hyperaldosteronism, ectopic ACTH, Cushing syndrome, severe hypokalemia. Clinical manifestation: vomiting, depletion, easy fatigability, postural dizziness, muscle cramp, hypokalemia, muscle weakness, arrhythmia, urine chloride less than 20 milliequivalent, saline response, urine chloride less than 20, low, go slow, so saline responsive, high, not go with the flow, so saline unresponsive. So treatment: treat the underlying cause to reverse the generation of all phase. In all cases, saline unresponsive, also give normal saline to correct the maintenance phase. Okay, now time for questions. Now look at this question. Now look at this question. A 60-year-old, look at the pH. pH is low, 7.08. PO2 is normal. PCO2 is high, more than 40, and bicarbonate is low. So PCO2 is nearly normal, but low bicarbonate, low bicarbonate. pH is very low, 7.08. Looks like metabolic acid. Okay, normally in here pH is low, bicarbonate is very low, so looks like the primary problem is metabolic acidosis. Now you need to see, is there any compensation happening or not. For seeing the compensation, we need a formula called Winter's formula, where we will find expected PaCO2 equal to 1.5 into bicarbonate, 1.5 into bicarbonate, that means 12 into 1.5, is 18. 1.5 into bicarbonate plus 8, that means 26 plus minus 2. So it is in between 24 to 28, or approximately the PCO2 should be 26. As there as there is not as it is not compensated, so we need to think there may be another secondary pathology too. So pH is low, PCO2 is high, reverse, that means it is respiratory acidosis. So in here there is mixed respiratory acidosis, sorry, mixed metabolic acidosis and respiratory acidosis. Mixed, it's a mixed acid base disorder. It's a mixed acid base disorder. Okay, so first of all, in mixed acid base disorder, you need to find evaluate pH. pH low, it is acidemia. pH low, it is acidemia. And we have identified the primary process. It is metabolic component. It is metabolic acidosis. Then we find the compensation. The expected compensation. The expected PaCO2 is 1.5 into bicarbonate plus 8 plus minus 2 according to Winter's formula. So as it is not compensated, looks like there is secondary pathology. So it is secondary primary disturbance. Okay, this is a chart you can remember, but very tough sometimes. If there is very low pH, then we suspect there may be mixed respiratory acidosis, mixed metabolic acidosis and respiratory acidosis. First of all, in metabolic acidosis, pH is low, PCO bicarbonate is low, and PCO2 should be low too, but in here PaCO2 is higher. So looks like there is a respiratory acidosis. Okay, if we see this question, uh, day long nausea, vomiting, okay, good. BMI, physical examination, there is dry skin turgor. Okay, what are the AVG findings? AVG finding first, what we can do, we can find out the anion gap. We can find 132 minus chloride 90. There is no bicarbonate. So this 19-year boy, physical examination, mucous membrane are very dry, skin turgor is decreased. There is diffuse tenderness on palpation. Sodium is 132, potassium is 5. Uh, potassium is 5. It looks like as the glucose is higher, it looks like it is decay, diabetic ketoacidosis. We know that decay is HAGMA, high anion metabolic acidosis. So in decay, pH is low, PaCO2 uh, is low, bicarbonate is also low. In metabolic acidosis, pH is low, PCO2 is low, and bicarbonate is low. It is actually diagnosed according to the stem. As the glucose is more than 450, looks like it's DKA. Okay, now next question. Look at here, ABG 7.31, pH is low, PCO2 is low, pH is low, PCO2 is low. So, and there is bicarbonate is low. So looks like it is metabolic acidosis. Now we can calculate 136 plus 4 like 140. So 136 minus chloride is 92 plus bicarbonate is 14. So 92 plus 14 is 106. So 136 minus 106 like high anion gap metabolic acidosis. High anion gap metabolic acidosis. What is the next step in the diagnosis? In metabolic acidosis, we need to do the serum osmolar gap. Serum osmolar gap very, very, very high yield. These boxes very high yield. If there is metabolic acidosis, we need to do the osmolar gap. How we can calculate the osmolar gap? It is measured minus calculated. How we can find the calculated? We have discussed the calculated is 2 into sodium plus 2 into sodium plus glucose by 8. Look here. 2 into sodium plus glucose by 18 and BUN by 2.8. Glucose by 18 and BUN by 2.8. So this way we can calculate the osmolarity, then measured minus calculated. If serum osmolar gap is more than 10, it is high. It may be due to me, that means methanol and ethylene glycol. If osmolar gap is high, it is me, methanol and ethylene glycol. If osmolar gap is less than 10, normal 10 milliosmol per kg, it may be ketoacidosis, it may be uremia, it may be D and L lactic acidosis. It may be salicylates. It may be pyroglutamic acidosis. It may be toluene. It may be toluene. If it is normal, anion gap less than 14, then you need to do urine anion gap. Urine anion gap, urine sodium plus potassium minus chloride. If urine anion gap is higher, it is distal RTA and type 4 RTA. How we can differentiate? The distal RTA has hypokalemia and type 4 RTA has hyperkalemia. And in urine anion gap, if it is negative, it may be due to diarrhea, proximal RTA and excess saline. Diarrhea, proximal RTA and excess saline. So I am reading this box again, that how you can evaluate evaluation of metabolic acidosis. In metabolic acidosis, we can remember the cause by mud piles, but if there is metabolic acidosis, first we need to do the serum anion gap. If serum anion gap is higher, then you should do urine anion gap. Serum anion gap is higher, you should do serum osmolar gap. If osmolar gap is high, that is methanol and ethylene glycol. If it is osmolar gap is normal, ketoacidosis, uremia, D and L, lactic acidosis, salicylates, pyroglutamate acidosis, and tolerance. And for normal anion gap, you should do urine anion gap. If urine anion gap is positive, it may be distal RTA or type 4 RTA. If it is negative, diarrhea, proximal RTA, and excess saline. Now look at this question. 15-year-old girl suicide attempt. Okay. hypertension, coronary artery disease. Okay. Physical examination. Which of the following sets are most likely observed in this patient? So in this stem, patient has a history of ingestion of 30 tablets, and then there is upper abdominal discomfort, ringing in the ear, looks like salicylate or aspirin salicylate toxicity. Um, in salicylate toxicity, there are two types of salicylate toxicity. One is normal anion gap metabolic acidosis. In normal anion gap metabolic acidosis, PCO2 is low, bicarbonate is low, but as it can be mixed, so different thing can happen. So this patient tinnitus, fever, tachypnea, nausea, salicylate intoxication due to aspirin that her father takes for coronary artery disease. Acute salicylate toxicity presents with mixed acid-base disturbance. There may be primary respiratory alkalosis, develop shortly after ingestion, and because salicylates directly stimulate the medullary respiratory center, resulting in increased ventilation and low PCO2. And primary anion metabolic acidosis develops after several hours. Toxic salicylate level inhibit oxidative phosphorylation where bicarbonate is low. So because two primary disturbance shift arterial pH in the opposite direction, and AVG often shows a near normal pH. So expected management in here according to Winter's formula, bicarbonate 14 1.5 plus 8 plus minus, so it is in between 27 to 31, but the bic PaCO2 is 23. It is lower, indicates a concomitant primary alkalosis. So in here, uh, respiratory acidosis with primary concomitant primary alkalosis working in other direction, there should be minimal compensation from for refractory so for respiratory alkalosis in the setting, and the significantly decreased bicarbonate 14 milliequivalent indicates a concomitant primary metabolic acidosis. So this patient potassium is higher like hyperkalemia, and if we do the ABG, if we do the calculation measuring anion gap, sodium 136 minus chloride is 108 plus bicarbonate. So 126. So 136 minus 126 equal to 10. It is normal anion gap, and there is hyperkalemia. So normal anion gap metabolic acidosis along with hyperkalemia looks like it is type 4 RTA. Very, very, very high yield to diagnose this type of diagnosis. Okay, look at here. This patient ABG, this patient's ABG pH is higher, PCO2 is higher, and oxygen is normal. And look at the bicarbonate. Bicarbonate is higher too. So it looks like metabolic alkalosis. It looks like metabolic alkalosis. Okay, and chloride count is low, potassium is low, so hypokalemic, hypochloremic, metabolic alkalosis. It may be due to small bowel obstruction. So hypokalemic, hypochloremic, metabolic alkalosis. In here, normal saline infusion should be done. Increase normal saline infusion. Okay, look at this question. Urine pH is higher, like alkalosis. If there is metabolic alkalosis, then we do urine chloride. If urine chloride is low, slow, go with the flow, that means saline responsive. As urine chloride is low, it is saline responsive. It may be due to vomiting, diuretic use. It may be vomiting, aspiration, and diuretic use. So metabolic alkalosis, then urinary chloride, low urine chloride looks like metabolic alkalosis. Okay, the final question. This patient has generalized tonic-clonic seizure. So we have discussed it earlier that if there is seizure, there is increase of postictal lactic acidosis. So lactic acid may be high, but it is completely resolved after 2 hours or after 90 minutes. So the patient has anion gap metabolic acidosis is likely due to postictal lactic acidosis. Seizure activity usually after tonic-clonic seizure can have skeletal muscle hypoxia. So postictal lactic acidosis is typically transient and self-limited, typically resolves within 90 minutes. So we told the patient to do lactic acid to do the anion gap after 2 hours. If the metabolic acidosis has not resolved, if the metabolic acidosis has not resolved, so other potential cause of metabolic acidosis like intoxication, sepsis should be investigated. That's all about metabolic acidosis and alkalosis. It's a very long video. Hope you enjoyed.